Welcome back to Cancer Buzz TV. I'm your host, Summer Johnson. This show is a resource of the Association of Community Cancer Centers, developed to bring oncology professionals the news and the latest trends in cancer care. In 2019, ACCC set out to define quality care for patients with advanced stage NSCLC. The name of the initiative is Fostering Excellence in Care and Outcomes in Patients with Stage 3 and 4 non-small cell lung cancer. And following a national survey, a panel of experts from across the country designed a set of quality measures and invited cancer centers to apply for a quality improvement program in partnership with ACCC to address those. Over the last year, 6 cancer centers went through the process, each with the goal to improve specific care and coordination areas within their own programs. Today, I'll look at the findings of one of those programs. Our guest today is Wendi Waugh. She's the Administrative Director of Cancer Services and Ambulatory Infusion Services at the Southern Ohio Medical Center. Let's get right into it, Wendi. Tell us a little bit about the community that you all serve at Southern Ohio.
Yeah, so Portsmouth, Ohio is located in really the tip of Appalachia. So we are on the Ohio River and close to Kentucky and about 30 minutes from West Virginia. So we call this area the tri-state area. And it's a very rural population. Sometimes people would travel potentially up to 60 miles one way to visit our facility. The closest tertiary centers might be Lexington, Kentucky, Columbus, Ohio, or Cincinnati, Ohio. So we're nestled right in the tip of Appalachia.
Why did you decide to participate in the process improvement program?
So really, the first clue to that was that we're in the tip of Appalachia. And so that makes our smoking rates one of the highest in the country, actually, where we live. We have 34 to 38% of the patients that we serve who are everyday current smokers, which makes lung cancer the number one diagnosed cancer at our facility, and also of course, the most deadly cancer at our facility. So I've really had the privilege of working with ACCC over time, and it started with actually the optimal care coordination model, in which we wanted to take a look at really what level of care we provided at SOMC and what gaps we needed to work on to improve lung cancer care. So after having a great experience on that first project, we were ready to jump in with both feet on this project.
Was it a big undertaking? What type of commitment did it require?
So no, the data that we gathered really was not a huge undertaking. It was very well thought out by the team, and we really had to do a small percentage of the population that we serve and do a little bit of data mining. I will admit that at the time that we started the program, some of our electronic medical records were disparate, so we had to do some mining in more than one system to come up with the data. But it was very interesting to look at the data and to examine, some of the things that we found with the data. And I feel like ACCC and the people that were involved in the project really listened to our concerns and, made it as easy for us as possible. The data lift was relatively simple. And we have a small team, so yeah.
I would imagine that the benefit of having the outside perspective was incredibly valuable.
Yeah, and I think that that's one of the reasons that we really wanted to participate in this project. We learned that with, again, the optimal care coordination model, in that, you can look at something all day long, but when it's your own process and what having someone from the outside take a look at that really gives a very different perspective, and really guided us and brought some perspective of what they had seen at other places that we hadn't had the privilege to be involved in. So yes, absolutely very beneficial.
You focused on two issues at your center. Let's take the first one, streamlining delivery of biomarker testing results. Tell us a little bit about what you were looking for and what you found.
Yeah, well, when we first got involved in the project, really, some of the biomarkers and genomics, precision medicine were just on the horizon, and really trying to get our arms around, how do we not only order the tests, process the tests, get these results to providers, and how could we quickly implement that for patient treatment? So what we recognized very early on, really with the data that we collected, is that we had multiple different providers that might be ordering the testing. And as I already mentioned, disparate medical records. So it was often not obvious whether the genomic testing had been ordered and or how the results were populated. And even when you did receive a report, some of those reports were 25, 30 pages long, and trying to decipher the actionable mutations and whether or not there was something that the patient we needed to implement for treatment was difficult to find. So we knew that we really wanted to take a look at that process and understand the barriers, the time, and what we needed to do to fix some of those things.
I heard that you had kind of an aha moment for your program that launched a domino effect. Can you tell us about that?
Yeah, the aha moment was when we really got to looking at the results. We recognized that the provider who ordered the result may or may not have even been informed that that result was back and ready. And certainly the providers weren't then moving or reacting to that result and saying, okay, when is this patient scheduled to see me? Do I need to move them up? Do I need to change their therapy? So what we did was involve the lung navigator, and essentially we created a portal with the company that we were using for our testing. And so all of the orders and the results sort of came to this centralized hub. And then we created discrete fields for all of these different results that would automatically inform the provider and populate to the provider's notes so that it was obvious the mutations that were there and what mutations were actionable for the patient. So it really improved the time from ordering to receiving to putting the treatment in action for the patient when there was an actionable mutation.
The other process improvement work that you undertook was trying to reduce ED visits. Would you describe that and tell us what you were able to put into place to enable real-time information about those patients admitted to the ED?
Right. Well, first of all, what we found out is that our lung cancer population were our most frequent flyers to the emergency room. And so we did actually several different things to help with that. So we want to classify those lung cancer patients as high risk. So the first thing we wanted to do was talk to the lung cancer patients about that. And we actually created, and this was with ACCC, a process through which we gave those patients a card that they could present when they came to the emergency room that informed the providers that they were on some type of targeted or immunotherapy or chemotherapy. So that's one. Number two, then the patient knew that we wanted them to contact us before going to the emergency room. That's two. Now, thirdly, we worked with our IS department to get a real-time report of those patients who were visiting the emergency room so that we, number one, knew that they were there, could follow up on what their concerns, what their issues or problems were, and see if we could have preventable visits for the future. So why did they go to the emergency room? Could they not get a hold of us? What was the rationale? What happened? Were they admitted? Was it a true emergency room visit, or was it a preventable emergency room visit? And Summer, what I didn't tell you is that we also participate in the oncology care model. So this was important to us, of course, for taking care of the patient and avoiding long ED visits and those kinds of things, but also from a quality perspective and payment perspective with the oncology care model.
You embarked on this with an emergency provider team in the middle of COVID. How did you keep this going when things got overwhelming?
So you know what? Here's the thing, and this to me is shocking, but during COVID, particularly during the very first stages of COVID, were our best ED visit rates. In other words, our lowest. So what it told me is that most of these ED visits were preventable, and patients did not want to go to the emergency room. They were afraid to go to the emergency room. So that in and of itself was evidence that those emergency room visits were preventable. So the challenge is now COVID is waning, and we're now managing, and we're getting back to everyday life practice. Why can't we create that you don't need to go to the emergency room? We are here. If we could do it then, why can't we do it now and going forward?
I'd like to switch now and talk about the multidisciplinary team that was involved. What did you find most valuable?
Sure. So one of the things that came out of the early participation in the optimal care coordination model was the formation of a lung health leadership team. And I will say we're very fortunate to have that team led by a thoracic surgeon, Dr. Jerry Martin, here at our facility. And Dr. Martin really worked very hard to involve a radiologist, the radiation oncologist, the medical oncologist, the pulmonologist, the navigation team, the administrative team in this lung health leadership team. So that team was looking at these metrics. So they're looking at time to treatment, which was affected by the first project that we talked about, right? That would be if you have an actionable mutation, when are you starting your chemotherapy? When are you starting your radiation therapy? And those sorts of things. And that team would be looking at those emergency department visit rates. So Dr. Martin really was instrumental in bringing together those provider groups, the radiology groups, and all those key stakeholders. So I attribute really the main success to the lung health leadership team, who did a lot of groundwork, a lot of talking and constant communication. Now, we're a pretty small center, and so we've been fortunate again to have a fairly closed network. I would imagine that this would be more difficult if you were in a large facility and had several different emergency groups to work with. So we only had a few.
What do you want to leave for cancer programs who may be considering a quality improvement approach?
I think the key thing is outside perspective. So I don't think any of this would have happened if we didn't involve and have a project. 2, metrics. So data analytics to say, this is a problem, this is where we are, this is where we need to get, and constant follow-up on that. And then 3, communication. So, and it's all about those leaders and how they disseminate, and it can't be done just once and just going to assume that it's going to stay the same, because like I said, staff changes, provider changes, patients change. So it's an ongoing evolution that you've got to continue with. And even with the metrics, so you make one improvement and you get some steam, then how are we going to continue to notch up and continue those improvements going. And so our lung health leadership team still meets today. We still look at these metrics today, and we're always looking at a better way forward.
Thank you, Wendi. You can find more information on this program on the ACCC website, including stories from the other cancer centers that participated and practical resources that you would need to implement these quality improvement programs at your own center. If you're enjoying this content, we would love it if you would let us know by leaving a review and sharing it with your colleagues. Also, you might want to check out the Cancer Buzz audio podcast channel. There, you can find even more programming on the latest topics in cancer care. Just search for Cancer Buzz on your favorite podcast app. On behalf of all of us here at Cancer Buzz TV, thank you for watching. I'm Summer Johnson.